So, could we proceed with Mr. Grigoriou, who is here to talk us about about depression and pregnancy.
Yeah. Now, this is the second one about the πρώτη είναι depression. Αυτό είναι. Ναι, συγγνώμη. Okay. Can we start? Okay. So good afternoon. My name is V Grigoriou and I'm a resident psychiatrist in the Psychiatric Hospital of Attica, Daphne. This presentation was supposed to be held by Dr. Petsas, but he was under extreme pressure, so I had the ethical obligation to do it. And I'm gonna skim through it a little bit. So, the title of this presentation is Depression and Pregnancy. We do know that up to 15% of pregnant or postpartum women will have depression, and half of them are meeting the criteria for a major depressive disorder. There is no difference on prevalence rate when compared with women in reproductive age, but who are not perinatal. We do know that relapses are more probable in women with more previous episodes, longer length of illness, and an episode in the 6 months prior to conception. Pregnant women with major depressive disorder do share some common characteristics which can affect the outcome of the pregnancy. These are the poor nutrition, the lack of exercise, they're not taking their vitamins, there's a poor compliance with prenatal care, there's increased smoking and alcohol usage, there are thoughts of self-harm and suicidal ideation, and we should pinpoint that the suicide in the first postpartum years is the leading cause of maternal death in England and in Australia. So we will try to pinpoint the effects of untreated depression. First of all, regarding the fetus, studies have shown that there is an altered fetal heart rate variability, there are changed movement and sleep patterns, there's a delayed fetal head and overall growth, and there have been measurements of increased C-reactive protein and pro-inflammatory cytokines. There's also an increased cortisol and corticotropin releasing hormone, and there are some potential epigenetic changes to placental Gs of the hippocampus pituitary adrenal axis. And now regarding the birth outcomes, there are several meta-analyses that suggest that small but significant increased risk of preterm birth and low birth weight. This can be attributed to increased cortisol and corticotropin releasing hormone and to low folate levels. So we see the effects that an untreated depression can have both to the fetus and to the birth outcome. So we do know that the use of antidepressants during pregnancy is common. The majority of prescriptions are for SSRIs, and due to concerns about teratogenicity, many women stop taking them prior or less than 6 weeks after the news that they are being pregnant are made known to them. Due to this abrupt stop, the relapse rates are high. It's 68% versus 26%. 68 to those who have stopped taking their antidepressants, and 26 to those who adhere to their medications. We do know that antidepressants are not major teratogens, but they can create some specific congenital malformations. The effects on early growth and neurodevelopment are poorly studied, yet most data are reassuring. There seems to be an association with preterm delivery, with respiratory distress and low APGAR score, and there is also an increased risk for hypertension, preeclampsia, and postpartum hemorrhage. And some newer studies have also associated the use of antidepressants with a small increase in the risk of childhood autism. So I'm going to pinpoint, first of all, the tricyclic antidepressants. and then we'll proceed with the most common used, the SSRIs. So we do know that regarding the tricyclic antidepressants, the fetal exposure is high. That has been the medication of choice in pregnancy for many years. And we do know that there has been a weak association between clomipramine and cardiovascular defects. And this association seems to be really valid because the SPC of the medication contains the lines that it should not be recommended during pregnancy. And there are some studies that pinpoint the fact that TCAs used during pregnancy can increase the risk for preterm delivery. Some studies recommend the use of nortriptyline and desipramine due to less anticholinergic and hypotensive effects. There have been neonatal withdrawal effects when TCAs are used in the third trimester. And these effects are agitation, irritability, and some respiratory distress in the neonates, which are mild and self-limiting. Now, regarding the SSRIs, even here we can say that these medications they do not appear to me to be major teratogens, and most data seem to be in favor of fluoxetine. And we do also know that there is the least placental exposure for sertraline. And regarding neurodevelopment, SSRIs are considered to be safe. It seems that depression itself is much more harmful, and that's why in these trials the confounding effect is depression itself. But that's why I have used the red color. Paroxetine has been associated with cardiac malformation, especially in higher dose, over 25 milligram per day in first trimester. So this is a medication that we should avoid. Now, we do also know that SSRIs are associated with decreased gestational age, spontaneous abortion, and decreased birth weight, but this can also be a credit to maternal depression. When they are taken in late pregnancy, we do know there is some kind of serotonergic toxicity, some discontinuation symptoms, and a risk of early birth. Now, regarding some venlafaxine, which is an SNRI, we do know that there have been some cardiac defects and anencephaly. And regarding mirtazapine, there are few data. So both of these medications, it is better to be not prescribed during pregnancy. So as we can see, and we will see this later on when we talk about psychosis, there is no ideal medication. The guidelines predict that depending on the symptom severity and the functioning, we should choose the medication or some non-pharmacological strategy. So when it comes to mild or moderate depression, we can taper and discontinue medication prior to or after conceiving, and non-pharmacological strategies can be really helpful. But when it comes to severe and recurrent depression, we should maintain medication even if the women are asymptomatic or minimally symptomatic when they conceive. Thank you for your patience.
So perfect. I want to congratulate myself for not making any mistake at all. It has been a great talk from your point, Vasilios. You always do. I would like to insist on the fact that when there's no severe depression, there's no dilemma. I just had one patient who was histrionic. Histrionic. She had no severe depression, and we just had to go on with the medication.
Yeah.
This was an exception yes, in my personal life.
This will be even more evident when we talk about psychosis, that each patient has to be treated individualized in an individualized way.
Yes.
With weighing the risks and the benefit of each case.
Yes. Yes, perfect, Vasilis. So, do you gonna?
Let's have a glass of water and then I can continue.
Yeah. Okay. Δεν ξέρω αν έχει εκεί τέτοιο. Ναι.
As long as they are clean. Okay.
Δεν ξέρω. You just bring one yourself. So, he was perfect. There's no question. How nice to see two colleagues who could possibly be talking about something today, but they didn't. You're the one, yes. Yes, Miss Sousa. Yes. Next year, we'll be waiting for you. So I hope Mr. Chopelas will also arrive. So don't hurry.
Yeah. Okay. So, yeah. So the title of my next presentation is Psychosis and Pregnancy. This is my main presentation, so I strive for it to be a little more analytical. The presentation is divided in three parts. In the first part, we will discuss the psychosocial perspective of a pregnancy in psychosis. Then we will offer some more data regarding the use of medication. And in the third and final part, I will offer a brief synopsis of genetic counseling. It is rather common knowledge that during the last decades there have been profound changes in the reproductive lives of women with psychosis. First of all, due to the destigmatization of the mental illness, there has been a higher access to marriage, along with the introduction of oral contraceptive pills and the second generation antipsychotics, along with the deinstitutionalization, has led to higher rates of sexual encounters and a certain degree higher rates of pregnancy. As always, the healthcare system was unprepared. There have been major shortcomings in pregnancy detection, in management of pharmacotherapy during pregnancy, in family planning, in housing for pregnant women, and in parenting rehabilitation. Maybe sexuality in psychosis can be considered a taboo, or maybe the healthcare system can only portray mental patients being locked up in an asylum. But even though sexuality is an aspect of the disease that it's not that has not been very well documented, we do know that psychosis does not diminish sexual desire or sexual activity. It is the quality of these sexual relationships that is rather problematic. We do know that patients suffering from psychosis have chaotic and unsatisfying sex lives. They have multiple partners and they have high rates of coerced and forced sex. They have a very limited knowledge about sexuality, about female anatomy, about contraception, and they have also limited impulse control, poor judgment, and comorbidity with drug and alcohol addiction. It's not difficult to understand that pregnancy, which by its origin is such a demanding period in the life of every woman, can be even more demanding and even more frustrating to a woman suffering from psychosis. We do know that many psychotic women have a delayed recognition of pregnancy and even they reach the extreme of a psychotic denial of its pregnancy. When they are being women who do not take antipsychotic drugs have not that kind of extreme worries about mothering that patients suffering from psychosis have. And as we said, there's also drug, alcohol, and nicotine abuse, which puts an extra burden in pregnancy. We do also know that due to the low socioeconomic status, pregnant psychotic women are less likely to receive prenatal care, and they have also higher rates of obstetric complications. What is really important for this woman is the fear of custody loss and the under-report of symptoms. It is in these cases, when these women have already experienced the deprivation of their first child, that they are psychotically denying their second pregnancy. And as mentioned before, there are very high rates of unplanned and unwanted pregnancies. This is why the concept of family planning is very important to psychotic women. As we said, there is a lack of basic knowledge of contraception. There's a lack of basic knowledge of human anatomy, and most women patients want family planning, and they want it inside the mental health settings. And follow-up studies have shown the success of these interventions, but they are the exception and not the canon. That's why a broad intervention is required, an intervention which should contain sex education and assertiveness trainers in psychosocial rehabilitation efforts, screening patients for HIV risk behaviors and HIV infections. Systems must be implemented for the early detection of pregnancy, and mandatory pregnancy tests must be held for patients of reproductive age. It is during the relapse that the optimal pharmacotherapy and strong psychosocial support is needed. And we must also improve the methods of assessing parenting capability, and we must intervene when needed. At this point, I would like to make a point that we do not have the time to properly analyze it, but when a woman is psychotic does not mean that she's not in the capability to fully bring up a child. That's why we have to establish methods of assessing this capability. So we should, by all means, include family planning in conjunction with mental health services. So, we do know that the untreated psychosis is an independent risk factor for congenital malformations and perinatal mortality. In contrary with some neurological disorders, pregnancy does not protect against relapse. And the perinatal psychosis risk is around 0.1 to 0.25 in general population. So an untreated psychosis can have a double way of risk. It can put the mother to harm through poor self-care, with a lack of proper obstetric care, or even impulsive acts, and it can hold a potential harm to fetus or neonate, which can reach the extreme of infanticide. So we do understand that there is a high risk of when we don't treat psychosis. But on the other hand, as we said in depression, there's no ideal medications. We do know that both the first generation, the second generation of antipsychotics carry a minimal risk for teratogenicity, and our years of expertise have shown that. We do know, though, that haloperidol may be associated with limb defects, but the risk is extremely low. And a recent prospective study have concluded that preterm birth and low birth weight were more common with first generation antipsychotics than second generation. When it comes to second generation antipsychotics, the risk of gestational diabetes, obesity, and metabolic syndrome may be increased with this medication. There seems to be more data for olanzapine, which is associated with lower birth weight, increased risk of intensive care admission, large head circumference, and with macrosomia. When it comes to clozapine, we do know that it's not associated with increased risk of malformation. Yet the NICE guidelines recommend an immediate switch to another antipsychotic. The thing is that when you have a patient in clozapine and you are going to switch him in another medication, the prospect of relapse is rather high. So this guideline is kind of ambiguous, I should say. But we do know that there seems to be a possible association with floppy baby syndrome, and it's a case of hypotonia of the baby. And when it comes to depot forms of our medication and to anticholinergic drugs, they should be avoided. In 2011, the FDA issued a warning for potential risk of abnormal muscle movements and withdrawal symptoms in newborns when their mothers were taking an antipsychotic in the third trimester. And this warning covers both the first generation and the second generation antipsychotics. Some other guidelines prescribe that there should be a discontinuation of the medication 5 or 10 days prior to delivery, but there should be a constant monitoring of the pregnant women, and we should be alert for withdrawal symptoms in the neonate. As I said, overall, there is no superior drug. What we must do is a highly individualized assessment of both the benefits and the risks. And later on, we'll talk about some general guidelines that will probably help us take the right decision. I will also cover some other medications that sometimes are being used in treating psychosis, or they can be when there's some kind of comorbidity, as with bipolar disorder. We do know that no mood stabilizer is clearly safe. Lithium has been associated with a congenital heart malformation, Epstein's anomaly, hypotonia, and lethargy, and that's why a frequent ultrasound check is being required. Carbamazepine and valproates are by all means medications that should be avoided. Both of them are associated with fetal abnormalities such as spina bifida, other neural tube defects, and lower IQ. And between them, valproate carries the higher risk. And if we have, by all means, and we don't have any other solution, the doses must be very low. At least the major dose should be around 1,000 milligrams a day, and there should be daily prescription of folic acid and vitamin K in order for the neural tube to be well constructed. Due to the fact that the previous two medications seem to have a red line when it comes to pregnancy, lamotrigine has a much safer profile, and it has been much more used in the late years. Topiramate has been associated with oral clefts, and there's also an FDA warning for this. Gabapentin has no major risk, and when it comes to benzodiazepines, there seems to be no major risk, but there is some kind of association with oral clefts, preterm birth, low birth weight, floppy baby syndrome, and neonatal withdrawal symptoms. So, at a certain point, we have to face the dilemma. Should we give or should we maintain our patients on its antipsychotic agent, or we should stop? These guidelines can help us put our thoughts on some kind of way to reach the answer, because the mental health of the mother influences the fetal well-being, the obstetric outcome, and child development. We must take into consideration the woman's ability to cope with an untreated illness. We must take into consideration the potential impact on the fetus, the risk of stopping medication abruptly, and it is no surprise that we must take into consideration the history of previous episodes, the response to the treatment, and of course the woman's preference. So, some general principles as guided by the Maudsley guidelines. When a woman is newly diagnosed, we should by all means avoid all drugs in the first trimester when the organs are being created. It is better to use established drugs, and it's better to continue a drug than switch to another drug during the duration of pregnancy. We must strive to have the lower effective dose, and we must strive to use drugs with the lowest known risk to mother and to the fetus. Also, polypharmacy is not an option, and we should use as few drugs as possible. And during the pregnancy, we must make the proper adjustment to the doses. As I said earlier, the abrupt stop is rather unwise. And when it comes to patients who are suffering from recurrent and repeated relapses, the antipsychotic should be maintained during and after pregnancy. As always, we must evaluate the benefit versus the risk. We should cooperate with pediatricians, and it is crucial to pinpoint the fact that parents must be involved in all decisions. I decided to address this review because what I read was rather shocking to me. It's not entirely up to date. It was published in 2009, but it covers papers up to 2004. It's a Cochrane review, and what is written is that at that point of time, at 2009, and there was a complete absence of objective trial-based evidence regarding the safety of antipsychotics. That was meaning that treatments based on clinical judgments and prescribing patterns could not be considered evidence-based. That means that there was no evidence-based medicine when it comes to pregnancy and antipsychotics, and doctors and psychiatrists actually were basing their option just on their clinical judgment and their past experience. So there's a great need for meaningful random controlled trials, and which should encompass the comparison between all kinds of treatment strategies, including also the non-pharmacological. I will provide just a brief mention to genetic counseling. It has been also addressed by Mr. Petsas. When there's a single parent, the risk is 10 or 12%. When there is both parents are schizophrenic, the rate is almost to 40%. And genetic counseling is a communication act that provides genetic information in a non-directive manner, facilitates decision-making, and supports the consultant and his or her family. That means that this option should be offered to all patients with psychosis. And the benefits are evident immediately. In most cases, consultants are relieved due to the lower actual risk. It is more or less the same as the survey that Mr. Petsas demonstrated, and can greatly help patients when they embark upon their family planning. And also, it can help early diagnosis and treatment of a child who has a higher risk of developing schizophrenia. This is an indicative bibliography that I used, and I'm going to end this presentation by saying that it's our double duty as psychiatrists to alleviate and to ease the pain, not only of the psychosis, but also the pain that is very evident in the pregnancy of psychotic women. Thank you very much.
Thank you very much, Mr. Grigoriou. It was an excellent presentation. I can say nothing more. You said absolute everything.
That's right.
I just want to point out the fact that having a pregnant woman in a psychiatric unit may be a matter of great concern. I mean, the experience of a woman being pregnant and being hospitalized at the same time is a very dangerous one. Many crucial dilemmas and questions arise, and it's very difficult to be answered. So, from my point of view, even if this is considered just not humanitarian, I would not agree for a woman to get pregnant if she's not ready to give care to her child. And a psychotic woman, in spite of the fact that we support psychotic people 100%, are rarely able to do so. And I want to ask Mr. Grigoriou, who is a psychiatrist with extremely big perspectives, huge perspectives. What is your opinion about that? Do you think that this position of mine is an anti-humanitarian, is a stigmatized position?
I would say that's a little bit radical, but I think that the concept of family planning, if it can be addressed in a tight way, can give answer to this kind of questions. Because if we manage to put the psychotic patient in a very circle of protection that has answer to all her needs, and I think we can at least try to see what's happening.
We can surely not, we cannot forbid, forbid a psychotic woman to give birth to a child. That's only.
We can augment the success rates and her well-being.
Yes, exactly, and some of us know the fact that one of our patients treated in the 4th psychiatric department was born from a mother who was epileptic and who was under phenytoin during her pregnancy. At the same time, the father was an undiagnosed psychotic person, and the conclusion was that the boy that this woman gave birth came up to be a psychotic person and someone who cannibalized his father. And it's surely something that nobody would like to see it happen. Anyway, you're right. It was a radical position. It was said just for you to say that, okay? And we have to have a dialogue upon those issues. I'm very happy that I heard you presenting once more. Congratulations. Thank you again. Gracias,